A patient with head and neck dermatitis variant of atopic dermatitis. Case presentation and history. A 29-year-old Caucasian man presented a 3-year history of uncontrolled atopic dermatitis. He did not respond to treatment with topical and systemic corticosteroids, antihistamines, emollients, oral antibiotics and topical antifungal agents. His medical history was significant for atopic dermatitis, asthma and allergic rhinitis. Clinical examination and investigation. A widespread erythematous and squamous skin eruption was located on the head, neck and the chest area was seen on physical examination. Serological test showed positive results for Malassezia sympodialis and for several allergens, including house dust mite, grass, mold and soy. Diagnosis. A diagnosis of atopic dermatitis was made. Management. A topical preparation containing 0.1% tacrolimus was added to regime of topical fluticasone, hydroxyzine, baling restrictions and emollients. After a few weeks, the therapy led to a stable remission on all the involved body parts of the patient. 2 months later, the dermatitis was almost cleared. A patient with debilitating dermatitis showing response to prolonged antifungal therapy. Case presentation and history. A 30-year-old man was referred to dermatology clinic with a 3-year history of progressively severe atopic dermatitis. Skin testing in past had shown immediate hypersensitivity to grass, cat, and dust mites. Clinical examination and investigation. Physical examination showed facial erythema with weeping lesions and dry erythematic trunk, especially back and shoulders. Skin cultures grew S. aureus, beta hemolytic streptococcus, and a skin fungus. A CBC, despite avoidance measures at home, showed 12.3% eosinophils. Diagnosis. A diagnosis of atopic dermatitis was made. Management. He was treated with fluconazole, 200 mg every day, and dicloxacin, 250 mg TDS, with subsequent decrease in skin erythema and resolution of exudative lesions on his face. Repeat eosinophil count after 8 weeks of therapy was 6.8%. However, 3 months later, his eczema recurred, weeping lesions on his face and erythema of his back and shoulders were noted. He was admitted to hospital, and CBC now showed 12.8% eosinophils. Skin cultures grew gram-negative rods and S. aureus. In light of the results of previous fungal cultures and his good response to antifungal therapy, he was treated aggressively with 40 mg of intravenous amphotericin B every day for 3 days. He was also treated with twice-daily moisturizing baths, containing surfactant and cottonseed oil, and tacrolimus ointment twice daily. He was discharged with a prescription of topical 0.1% tacrolimus. On 2-week follow-up, he had an estimated 50% decrease in facial and trunk erythema and clearing of the exudative lesions. When seen in follow-up 8 weeks after discharge, his skin, especially his face, showed significant resolution of erythema and no evidence of infection. A case report on chronic atopic dermatitis. Case presentation and history. A 30-year-old male presented extensive eczematous dermatitis that started behind his knees at the age of 26 years and steadily worsened to include the popliteal and antecubital fossae, arms and abdomen. He had a history of chronic atopic dermatitis with recurrent skin infections. He scratched the lesions, especially at night, with the result that his sleep was disturbed. Despite the use of chronic moisturizing therapy and topical corticosteroids, he had seasonal flares of eczema during the winter months. His family history revealed that his father has asthma and his younger sister has allergic rhinitis and cow's milk allergy. Clinical examination and investigation. Skin examination demonstrated scattered scaly eczematous patches along the flexural areas of his upper and lower extremities. Empatico crust-like lesions with serum oozing were found on the left elbow. Diagnosis: chronic atopic dermatitis. Management: as he was symptomatic despite traditional emollient and topical corticosteroid therapy, he was started on cyclosporin and topical tacrolimus. After a few weeks, the therapy led to a stable remission.